Okay. Good afternoon. I am thrilled to introduce Dr. Paul Schyve, who has graciously agreed to join me in opening the third annual Paul and Schyve MD Conference on Bioethics. Dr. Schyve received his undergraduate degree from the University of Rochester, where he was elected Phi Beta Kappa. He completed his medical education and residency in psychiatry at the University of Rochester and subsequently held a variety of professional and academic appointments in the areas of mental health and hospital administration, including as director of the Illinois State Psychiatric Institute and clinical associate professor of psychiatry at the University of Chicago. Dr. Schyve joined the Joint Commission in 1986, originally serving as the director of standards. From 1993 until 2011, Dr. Schyve was senior vice president and retired as senior advisor, healthcare improvement at the Joint Commission. Amongst his many professional activities, Dr. Schyve served as the founding advisor of Consumer Advancing Patient Safety, the chair of the Ethical Force Oversight Body of the Institute of Ethics at the American Medical Association, a former trustee of the United States Pharmacopoeia Convention, and a former member of the board of directors of the National Alliance for Health Information Technology. He has served on numerous advisory panels for the Centers of Medicare and Medicaid Services, the Agency for Healthcare Research and Quality, and the Institute of Medicine. Dr. Schyve published in the areas of psychiatric treatment and research, psychopharmacology, quality assurance, continuous quality improvement, healthcare accreditation, patient safety, healthcare ethics, and cultural and linguistic competence. We are excited about Dr. Schyve's participation in a pre-conference conversation as we focus on this year's conference theme, Family Matters, Families Matter, a topic that Paul enthusiastically supports. No surprise, as it is a critical component of the biopsychosocial approach that he learned and practiced while a student and trainee at the University of Rochester, and was integral to both his clinical practice and work at the Joint Commission. So, Paul, welcome. Thank you for your willingness to have a brief conversation with me on this year's conference theme, Family Matters, Families Matter. When I shared with you the subject matter, you mentioned your mentors, Dr. Lyman Wynn and his wife, Adele Lyman, a marriage and family therapist, and their joint work on family therapy. Paul, I would love for you to describe in a bit more detail about your mentors and their work on family relationships and its integration within the biopsychosocial approach.
Thank you, Lainey. While I was a medical student at Rochester, Dr. John Romano was the chair of psychiatry, and Dr. George Engel, they were both two of my mentors, given my expressed interest in specializing in psychiatry. They, of course, were the authors of the biopsychosocial model. So I was steeped in its principles and ideas from the beginning of my medical career. When I began my residency in psychiatry, Dr. Lyman Wynn had just become chairman of psychiatry. He had been a leader in stressing the importance of the family, in understanding mental illness and its treatment, and on the effects of a mentally ill member on the rest of the family. So he, with his favorite co-therapist, his wife Adele, taught us about the family within the biopsychosocial model. The biological related to genetics and to illnesses in family members, the psychological related to the personalities and coping styles of family members, and the social related to the cultural, ethnic, religious, educational, and socioeconomic milieu of the family and their interpersonal relationships. It would have been impossible to complete a residency under Lyman Wynn without understanding the importance of the family in the context of the biopsychosocial model. Of course, we sometimes learn things about families that Lyman hadn't intended to teach, like the time when he and Odell made a video of a family therapy session for the residents. The video opened with 4 empty chairs, and Adele and a couple entered and sat down. The view kept changing. The camera obviously was going side to side and in and out and up and down. Finally, Adele, obviously exasperated, said, "Lyman, just leave the camera alone and sit down." which he immediately did. Their openness in teaching was, I think, reflected in the fact that they didn't edit that out.
Thank you, Paul. I was also hoping you could talk about your own work on families in the context of language, culture, and community, and how you incorporated this into your work at the Joint Commission.
Well, when I came to the Joint Commission in 1986, there was a preface in the hospital accreditation manual that spoke about a patient's right to be treated with respect. But this wasn't part of the accreditation requirements or the survey process. Shortly after I arrived, we decided to adopt standards that would be surveyed and would be more explicit on what respect meant in terms of behavior. It started small. For example, a right for the patient to be informed and to make informed decisions about their care and not to be discriminated against because of ethnicity, race, religion, or sex. Soon, other specific expectations were added. For example, on research and on the need to establish policies on resuscitation and on withholding or withdrawing life-sustaining treatments. Often the Joint Commission didn't prescribe the actual particulars of the policy, but forced the hospital to think through the relevant ethical uncertainties and conflicts and to decide for itself how they would be clarified and resolved. Throughout this developing process, the Joint Commission believed and taught that ethical behavior in healthcare is not just an add-on to the quality and safety of care. Rather, it's in a reciprocal relationship to quality and safety. Ethical behavior is an integral component of the quality and safety of care, and conversely, the quality and safety of care are integral components of ethical care. Within this overall context of patient rights, the Commission would identify additional social factors that would influence the quality and safety of care, and therefore were ethical issues in designing and delivering care. These included language barriers and cultural barriers. How can a person be informed or give informed consent if language or cultural differences inhibit communication and understanding between the patient, their family, and the caregivers? It was also clear both from everyday practice and from the literature that people from different cultural backgrounds perceive and understand the world differently and have different values in addressing the challenges they face. They have different understandings about health, about illness, and about their treatments. These differences may or may not be recognized, let alone understood, in communication with healthcare personnel, especially when language barriers are also present. In addition, we now know that even the structure and vocabulary of a language both reflects and influences our perception and understanding of the world and of ourselves. This is why even a person who is proficient in two languages may find themselves more comfortable in the language of birth when addressing life and death issues, since it better reflects how they perceive the world. Another example of a cultural difference, the role of the family usually plays in the illness and treatment of a member and in relations with the healthcare professionals varies among cultures. These considerations led to the introduction of standards not only on language translation, but also on the need for policies and education on addressing cultural barriers in the population served, so-called cultural competence. In this context, of course, problems will still arise. For example, how to address a situation in which the only available translator for a woman is her 10-year-old child. So standards are strengthened on the availability of translation services, at least for the languages commonly represented in the population served by that location. Nevertheless, under the pressure of the moment, it is still tempting for the physician, the nurse, the social worker to think, I know a little Spanish, I won't wait for an interpreter, never recognizing the harm that may come. Of course, even a fluent translator may not share the patient's cultural background. The translator may not fully understand how the particular patient understands the meaning of the communication or what their values are. It would be best to share not only language, but also cultural background in the broadest sense. That is why in a multicultural society, it is critical to have cultural diversity within the healthcare staff, not just proficient language translators, because this diversity will affect the quality and safety of care. It too is an ethical issue in healthcare.
Thanks, Paul. The psychological, social, and cultural issues you described are even more acute today as our country grows more diverse and many families want to maintain their ancestral linguistic and cultural identities. I would appreciate if you could describe how you navigated incorporating family and ethics into policy at the Joint Commission more broadly. Please share some words of advice on how to promote ethical standards in practice, guidelines, and hospital policies in a pluralistic community like the United States.
Well, based on our knowledge and experience, the Joint Commission made three assumptions. First, the quality and safety of care are components of the ethics of care and vice versa. Second, the quality and safety of care are impacted by the language and cultures of the patient and the healthcare personnel. And third, the family is central to both the language and cultural milieu and identity of the patient, as well as to the diagnosis and treatment. Those assumptions, of course, lead to two conclusions. First, the family plays a critical role, both directly and indirectly, in providing quality and safe care to a patient. And second, understanding and addressing cultural differences play a critical role in providing quality and safe care to the patient. Historically, in drafting accreditation standards, we would convene a group of the relevant stakeholders: content experts, doctors, nurses, administrators, consumers and patient representatives, government representatives, etc. And then the draft standards would be sent out to hundreds more of these stakeholders for review and comment. We always learned a lot and almost always revised the standards before adoption. The process leads not only to more effective standards, but also to more acceptance and compliance. But frankly, we often lack the input of other cultures in this process. Today, in our multicultural society, I would advocate including a diversity of cultural and family perspectives in this development process. And I suggest the inclusion of cultural diversity in the broadest sense is especially important in the development of standards and practice and organizational policies related to ethical issues and practices because they are so value-laden. When this process is likely to be messier and more contentious, nevertheless, it will yield more effective standards and policies. So as you discuss value-laden ethical issues related to family matters, families matter, I urge you to keep in mind that our multicultural society, families come from, embody, reflect, and instill in their members different cultural perspectives and values. And these different perspectives and values will affect the relationships to the healthcare system and healthcare professionals and with their illnesses and their treatments.
Paul, your message is clear. Inclusion and diversity are central to the development of ethical and effective standards of practice. Thank you. And so on that note, I want to thank you again for your vision in sponsoring the Paul M. Schyve MD Center for Bioethics and having one of its goals to be outreach, to bring bioethics to the community. This third annual conference is being held with the support of Upstate Medical School and Albany College of Medicine. Healthcare and allied healthcare students, trainees, and professionals from many different disciplines from all over Western and upstate New York have registered to attend. The conference is open to community members as well, as the issues we will discuss are relevant to all of us who interact with healthcare systems, whether as clinicians or as patients or as family members of patients. So, Paul, thanks again for opening the conference. We would love to introduce you in person next year. Be well.
Thank you, Lainey. I wish you all a successful sharing and learning experience.